Okay, so now we're going to, so we've finished days 1, 2 and 3 of actual FREC course, and we're now going to continue to day 4. Does anybody have any questions on anything we've covered so far? The videos of my teaching and Richard's teaching today will be, I mean, my teaching is available already, what we've done, and I'll be uploading this later this evening as well. So that should be there for everybody to watch, should you so feel like you need something to help you fall asleep. Yeah, okay. And I know you've all been able to access it, but I know that no one's watched the last videos.
In what circumstances would we use the single mark?
That one.
That specific one.
That specific one, when you want the trustees to get really annoyed with you.
After a major incident.
After a major incident. If someone's drunk a lot of antifreeze, that's when you'd give them single malt.
Yeah.
Right, lovely something for
Okay, so what we're going to move on to now is we're going to look at head and spinal injuries. So we've spoken about limb injuries before, we've spoken about abdominal injuries, we're now going to move on to head and spinal injuries, okay? We're going to talk about the different types of head injuries. We're going to think about what sort of things they might present with, and we'll think about how we recognise some of these injuries as well. We're going to try and also look at how we do manual inline stabilisation, log rolling, and think about manual handling for patients who have spinal injuries, to how we prevent any worsening of the injuries, okay? We will get on to motorcycle and other helmet removal, but that's not the plan for this evening. Okay? So what type of head injuries might we come across?
down the stairs.
So blunt force to the head. Yeah. What sort of injury might we see?
Like the mechanics of it, or what happens in it?
How does it present?
Gash.
Yeah. So we might have a gash on the head. Yeah. So you might see a gash. What might that gash be doing?
Bleeding.
It might be bleeding. Yeah. What else might it be doing?
Swellies. Bump.
It might be a bump. Yeah.
Big bump on the head.
Yeah. So you might have a flap that's come off. You might have a gash that's just bleeding profusely. You might not have a gash, it might just be swollen. What else might we see?
Fracture.
We might see a fracture, yes, so we might see an abnormally shaped skull, and not because that's how the patient's skull was beforehand, because they've just had an injury. Okay? What else might we see?
Something stuck in it.
You might see something stuck in it, yeah?
You know,
What else?
brain matter.
Yeah, if it's broken, you might see brain matter. Anything else?
Confusion. Confusion.
So they might come across as being confused, yeah? Anything else? Don't forget, we might see nothing and they still have an injury. So there are some brain injuries where we won't see anything, okay?
Internal.
So it'll be something internal, but when you look at the patient, you can't see any obvious injury, okay? So we spoke about contusions or concussion, okay, or internal bleeding. So these injuries happen by the brain hitting the skull, okay? So the skull is intact, but the brain has hit it and been injured by that, okay? So the brain is normally suspended in the skull in fluid, which means that it can move around, and if it moves fast enough, it will move through that fluid and hit the bone, and then essentially get a bruise, okay? And that can cause it to not function normally. So you know how we ask when someone's had a knock to the head, have they had a period of loss of consciousness? Because it might be that the brain has been switched off and rebooted and they're now awake, but that's quite a significant injury if that's happened. Okay, and it's caused by that shaking motion. So when we quite often see people say they've got a bit of concussion, there's no such thing as a bit of concussion. You either have concussion or you don't. But it's that injury where everything looks completely intact, but the brain has been hit against the skull and has become bruised.
This is what we see in the babies that are shaken.
Yeah, so shaken babies, that's exactly what happens to them. They get shaken and their brain hits the skull and it causes bleeding into the brain and it causes problems with that.
They
Okay?
have a less liquid around the brain.
They don't have less liquid around the brain, they have more brain in their skull. So the older you are, the less brain you have. Unfortunately, that's very true. And once you've lost enough brain, you become demented. So if you look at CT scans of young adults, the skull is there and the brain is literally packing out the entire skull. And when you do scans of older people's heads in the 60s, 70s, 80s, then the brain is all shrunken down and there's quite a large gap between the brain and the skull. Okay? And the larger that gap, the less brain they have because the skull doesn't change shape after puberty. So it's the brain that they're losing, it's not that the skull has become bigger.
Is there a higher chance of concussion because there's more movement?
There's less chance of concussion because there's more space for the brain to move it. But there's injuries that are associated with that because remember the brain is suspended in water but it still has to have a blood supply. So we'll still have blood vessels running across. So there are other injuries that can happen with that. But older people who have less brain are slightly less at risk of having a concussion. It's not going to get them out of jail, unfortunately. If they have a hard enough knock, they can still get concussion.
And the head's more fragile as well. Because it's the higher
They'll have other issues with it as well, absolutely, yes. But the pathology of dementia is loss of brain. Okay? And that's why if everybody lives long enough, and we're talking about into their 150s, 160s, everybody would eventually get dementia. Because it's a natural process. Most of us don't live that long, so it's not a problem. Some of us have less brain to start off with, and it does become a problem. But that's why doing the Times crossword or all these puzzles are to a degree protective against dementia because you're having to make the brain work harder, and that's what preserves the
Is
brain.
it like to do with like older people also their muscles get smaller as well?
Yeah. Yes. So as we age, things get smaller, and that's why, and the brain is affected in that way as well.
Like a muscle.
Yes, if you don't, it's like a muscle in that if you don't use it, you lose it. Okay. So things that we would typically see in someone who's had a concussion is they've had this very brief period where they've lost consciousness. Okay. So quite commonly we'll see, we'll go to people who've been in an accident and they're sitting by the side of the road talking to you, everything looks absolutely, they're supposedly fine, but they tell you no, they came off whatever vehicle they came off, and there was a short period of time where they weren't responding at all, a short period of unresponsiveness, and then they started responding. So that initial impact essentially switches the brain off, for want of a better term, and they lose consciousness, and then it starts up again and they become conscious again. But the problem is that injury, we don't know how it's going to evolve. So it could then cause swelling, or it could cause bleeding, and it might cause pressure on the brain, and then they might become worse again.
Or nothing.
Or nothing.
You can have concussion without.
So I see lots of people who have concussion, and they come in to tell me about the awful headache, but they're absolutely fine apart from the awful headache.
Yeah.
And with 2 weeks later, I say to them, really sorry, but you need to take painkillers because the brain will eventually, because it will heal, but it takes time. And that's where the point where we're not worried because they've withstood the test of time for the swelling to happen or the bleeding to happen. But you can't tell what will happen in the future. And if any of you can tell what will happen in the future, please come to me afterwards. I would like to know this week's lottery numbers with a guarantee that I will win. And Richard isn't going to share it with me this week. You can share it with him next week.
where's the vomiting come from the concussion? Is that because the brain's confused?
Yeah. So it affects the vomiting. It can affect the vomiting centre in the brain and cause the vomiting as well. And that's what we're worried about with that vomiting, is that the vomiting centre in the brain is swelling up, causing the vomiting. Okay. The other thing is, depends which part of the brain has been impacted. There might be a loss of short-term memory. So short-term memory is laid down in the hippocampus of the brain, so right in the centre of the brain, and if that gets disrupted, there can be a period of time when the person can't remember anything. So you'll go to the person and you'll introduce yourself. So in my case, I'm Dr. Friedman Sola, and they say, yes, hello, nice to meet you. And 2 minutes later, you say to them, and who are you? And they're not putting it on. That's the difficult thing. You have to understand that they're not putting it on. They really can't remember who you are. And it's a new thing. It's not when you go to see someone who's very demented and this part of the brain doesn't work and they have no idea who you are. And everybody looks like their mother if they're female, and they look like their father if they're male, because they regress to old memories, and that's what they remember. Okay. So it's a very different type of memory loss. Okay. And it will usually be around the event that happened to them, so they won't remember the injury, and they won't remember things just beforehand, and they won't necessarily remember things afterwards for a short period of time. They might be quite irritable. There's a genetic variation, so if you're a man, you're more likely to be irritable, whereas if you're a lady, you're more likely to be confused and asking things repeatedly. And that's because people who have 2 X chromosomes brains are different to people who have an X and a Y chromosomes brain.
Males have an X and Y,
Yeah. And it doesn't matter what their body looks like. If they've got an X and a Y, they're more likely to be irritable, and if they've got 2 X's, they're more likely to be repeating things and confused. Because testosterone makes you fight out against everything when you're confused. Okay. They'll usually complain of a mild but general headache, which just doesn't get better with any of the normal things that get headaches better. And that's one of the hallmarks of that injury, because the brain isn't very good at feeling. It doesn't have very good sensation. So they'll have this mild headache, not too bad, but they've tried paracetamol, they've tried ibuprofen, they've tried cocodamol, it hasn't touched it. It stays exactly the same, because the problem isn't with how they feel pain, the problem is with the brain itself. Depends again which part of the brain. They might be pale, they might be clammy if it's affected the sympathetic or the parasympathetic nerves. So these are the nerves that automatically control our heart rate, blood pressure, and breathing and circulation. So if these nerves have been affected, then they'll have a problem with controlling that. So their breathing might not be quite normal. Their pulse might be quite shallow and rapid because they can't control it. Their pupils they'll be normal, because that's the part of the brain that doesn't get affected by this. Because while the eyes are very protected, it's quite difficult to put enough pressure on them, and it's quite difficult to affect the part of the brain that controls that. So the eyes will probably be normal in a concussion. So they'll have normal pupils. The pupils will react normally when you shine a torch into them. Okay. And then we spoke about have this intractable nausea, which is the feeling of wanting to be sick, or they'll be vomiting. And this intractable vomiting, which isn't caused by them being sick, but it's because the brain isn't functioning properly and it's making them sick. Okay. If they don't have any other symptoms other than the concussion, they will make a full recovery. But it can take 4 to 6 weeks. And you can see how debilitating that can be when that happens. Okay?
Do you have a headache for 4 to 6 weeks for it?
What?
You have a headache for 4 to 6 weeks?
Yeah. Can you imagine having a headache for 6 weeks? No. Exactly.
That's what I'm saying. It's extreme.
Yeah. It can be extremely debilitating because of this. Okay. So people say, I have a mild concussion. Well, no, it can be quite a nasty thing. Okay. But the thing is, you won't see anything. There's no visible change when they get this injury. Okay, so they'll look completely normal, but they've had a knock to the head, and they've had a short period. They may or may not have had a short period of time where they were unconscious, but they come back, and they may or may not have any of these symptoms, but they'll have a headache, which doesn't get better. Okay? and it can be quite difficult to tell it apart, especially just there at the beginning, so you do need to be careful with these things. Okay. We can then get bleeds in the brain, so we can get bleeding within the brain itself, and they'll present with stroke type symptoms, or the bleeding might be around the brain, so it's in the gap between the lining of the brain, between the dura mater, which is a thick lining which is attached to the skull, and the brain itself, and so that will be quite irritating, and they might present very similarly to a concussion. Or they might get a bleed between the dura mater and the skull, and that's usually an arterial bleed, and it's a high pressure bleed, and it gradually increases, and as it does that, it compresses the brain. So again, they'll present with signs suggestive of stroke, because that as the brain gets compressed, the bit that's compressed stops working. Okay. It literally squashes the brain, so the person, again, might be completely fine to begin with, but then as this develops, it will gradually get worse and worse and worse. So the classic older person who's fallen out of bed and is on a blood thinner, and you pick them up and they're completely fine, and then they're found that evening by the next carer to turn up dead in bed. They've had a subdural bleed which has been quite big, they've been on a blood thinner, and it's basically pushed their brain out of their skull into the spinal cord. And the brain is still, even though it does shrink as we get older, it's still much larger than the hole there, and compressed brain through a small hole doesn't work. So they die from that.
Really? What, they really squeeze the brain?
Yeah, they can literally force the brain out of the skull into the spine.
Wow.
It is not out. They don't feel anything. They literally feel absolutely nothing. But they die because the brain stem, which is the really important bit at keeping them alive, gets compressed and stops working.
And that when you see those patients, after you see them for a while, they typically present in a similar way,
Yeah.
and you already know at that point that probably that what they've got is not so right.
Yeah.
Even for brain, even in surgery, it's not.
Yeah.
How are they presenting?
So they present with a reduced level of consciousness. Yeah. Their breathing pattern becomes quite an on and off breathing pattern.
Yeah.
Their heart rate tends to go up and the blood pressure tends to go down, and then their blood pressure shoots up because it's trying to compensate for all this pressure in the brain, and the heart rate goes down because of that, and also the position that the body takes with it is quite characteristic. They become very stiff with it, and they don't really move normally with it as well.
It's a thing we call posturing, so they go like that or they go like that.
Yeah. Okay. And the treatment for it is to drill a hole in their skull, but usually these patients are so unwell to begin with that they would die from having the hole drilled in their skull.
Because that would release the pressure.
Yeah. Now, having said that, there are plenty of very, very old skulls dug up in archaeological digs that clearly have had holes drilled into them, and the person has survived because it's healed. So it is something that sometimes can be done. Okay, and it depends where it's picked up. The neurosurgeons in Queen's Square may or may not offer to do it, to drill a burr hole into the skull to take the pressure off. So just so we understand, the brain has that sort of consistency that looks a little bit like toothpaste, and it also looks that sort of greyish colour. And the pressure in the brain, in the skull, is about 10 millimeters of mercury higher than the systolic blood pressure to maintain that blood circulation within the brain. So as the pressure in the skull increases, the blood pressure will go up and up and up. So that's something that we might see with these patients. So I'll have a blood pressure of 190, 200 after an injury like this. Okay. Does that all make sense? Okay. So sometimes they'll have a history of a head injury with where they said yes, they'd fallen out, they bumped their head, they got better, and then they gradually deteriorate. Okay. As the bleeding gets worse, the level of consciousness will gradually go lower and lower and lower. They tend to have a really, really intense headache because although the brain itself doesn't have a lot of nerves in it, the linings around the brain are very, very sensitive. So when it gets infected, which is meningitis, we know those patients have an absolutely awful headache, and they're really sensitive, and everything aggravates it. It's because the lining of the brain is so sensitive. Or if someone has a sudden bleed into that, again, they describe it as the worst headache that they've ever had in their life, and it's completely nothing touches it. It's the worst headache. And it's like that. They'll have flushed, dry skin again because this is affecting their sympathetic and parasympathetic systems. So the way the body controls blood pressure and circulation gets affected by it. As I said, they'll have this on-off type breathing, so it will be quite deep, it'll be quite slow, almost like a sighing type breathing, and that's because of the pressure on the part of the brain that's controlling it. Their pulse will be slow, but the blood pressure will be quite high, so it will be a very strong pulse as well. Okay? Depends which side of the brain is getting squashed. So if one side of the brain is being squashed more than the other, so the pupils will react depending on corneal number. If it's pressing both sides of the brain equally, then both of them will be affected. Okay? But it typically will affect one side more than the other, because usually an injury is on the side of the head, not right in the centre, so the bleeding will be pressing the brain from that side towards the other side. Okay? As it progresses, because the brain isn't working the way it should, you can then start developing seizures as well. So again, as things progress, so they'll have this reducing level of consciousness, this abnormal posture, and then they might have seizures as well because of it. Okay. Unfortunately, if it's left, they will not recover. Okay, because all that will happen is the brain continues to get squeezed. Eventually, it gets squeezed out of the skull into the spinal cord. But the hole for that to happen, which is called the foramen magnum, is only about an inch wide, and the brain in every living person is bigger than that. So it's a non-survivable type of injury. Okay. So we've spoken before about injuries.
So that's not called concussion. That's called compression.
That's compression. So concussion is where there's no bleeding, but there's interruption to the brain's function because of the brain hitting the skull. When you get bleed in the brain, then it will start compressing the brain.
What do we do?
What do we do? Recognize it, take them to hospital, get them a scan of their head, and hopefully it's not bad enough to kill them, but bad enough for the neurosurgeons to want to operate, and they get operated on and they have a drain and they get better. The other thing is, it might, if it's not too high pressure, then the bleed compresses itself and it stops, and then they make a recovery. Okay, but if it doesn't stop and it continues, then eventually it will compress the brain until the person dies. So it's about recognizing it. Okay, and there's something that we call Cushing's triad, which is three signs that we'll find in patients with these symptoms, which is an extremely raised blood pressure, a slow, strong heartbeat, and a slow, sighing, deep breathing pattern. It's to do with the compression of the brainstem and the pressure that they need to maintain the circulation in the brain. Yeah.
And how hard does someone have to be hit to have this type of?
So it depends on lots of factors.
Right.
I've seen plenty of older people who've fallen out of bed who've had a subdural hemorrhage. Some of them have died because of it.
Subdural hemorrhages.
Yes, where the bleed compresses, it goes between the skull and the lining of the brain and compresses it down. Some of them have died from it, and it's a non-recoverable injury for them. Lots of people, especially older people, where they have the advantage that the brain is shrunken down with age, they have that much bit more space, and therefore they do survive it. But if it continues bleeding, then that's where all the problems.
So I did a piece of work for East of England recently, I think about the last 5 years, 7 years of data from patients that we missed in terms of major trauma. So they went to a local hospital and were picked up later on. All of them were over 65, almost all of them were missed for falls. They presented with a very high level of consciousness, so almost normal. And all of them that had brain bleeds had a very minor fall when they were looked at by ambulance crews.
Yeah.
So it doesn't take much when you get older and you're on blood thinners for that actually to be
Right.
removed.
So I mean, if someone fell out of bed and they,
Yeah.
and,
So
they got it and the thing just get them to
Yeah.
hospital,
Yeah.
even if they're absolutely
because you
fine.
can't see what's happened inside.
If someone's got a bump on their head, you
Yeah.
get them to hospital.
Absolutely, yes. And the hospital will scan them and scan people like this probably, 100 times a day? And I'm talking about a small hospital like Barnet, will probably do about 100 of these scans a day quite easily.
Right.
And remember, the benefit for these patients if they find they have a bleed is quite high, and the risk to them from a scan, because they're usually older, is quite low. So it's quite an important thing. I mean, I've seen someone break their neck by falling out of bed, and they
Right.
walked into A&E. So it does happen. But you have to be careful with these because these patients are that much more fragile. And it depends which part of the country you're in.
Can't just say, oh, he's bumped his head, but he's fine. You'll be alright. Have some painkillers.
Yeah, so it's not, oh, you'll be fine. You'll probably be fine, but the risks to you from bumping your head are massive.
Yeah.
But it's
Anybody.
definitely age-related.
It's an age related, yes, it is. Well,
So
it's a frailty related. So as we get older,
There's
our
someone-
body's less able to cope with injuries.
Someone in their 20s who
Fall out of bed.
Fell off their bike.
Who potentially could have the same injuries, but they're less likely to have those injuries as people get older. And it depends on the part of the country you are as to what old is defined as. Because there are some places where you get to the age of 50 and you're already and they define you as a geriatric patient. Whereas there are other parts of the country where you have to be 85 to be considered a geriatric patient. No, I mean there's variation even within London.
with the age of pensions going up now, so
Yeah, it's nothing to do with the age of the pension, but I'm saying
yeah.
it depends on the local population health, where the worse the population health is, the lower the age at which these sort of injuries happen. So if you go to a very deprived area, the risk of these injuries is much higher than if you go to a very wealthy area. Yeah? So if you get called to this state on broadfields, at the end of broadfields, where it's people who are very deprived, their risk of injury is much higher than if you go to one of the fancy houses on Pensets Gardens. And it's to do with health determination from when you're much younger. Okay, so all those who lived through the war and rationing after the war and made it and are still alive today are relatively healthier than the generation after them who didn't go through that. So when you're young, that's the important bit, to make sure you're healthy.
Why?
Because it's the basis that is important. Okay.
So what did they have different to the
What-
foreign?
They had
Fish and chips every day.
they had a healthy diet,
Okay.
which was extremely healthy because it was rationed. They didn't use personal transport, so they walked and exercised all the time. And that's basically it.
Instead of front of the PlayStation.
Yeah. Whereas the generation who ate rubbish and drove around everywhere, which is the next generation, is a lot frailer. Okay. So you'll see 70-year-olds who are less healthy than 90-year-olds nowadays. Doesn't mean that the 90-year-olds aren't at risk of having lots of really bad things, because at 90 you're much more likely to have lots of health conditions, but there's a generational change there because of the changes with rationing and public transport and everything.
Does anybody want any more cakes with risks?
Now you say that, but they still ate cakes, crisps and sweets.
So they were homemade cakes.
But they were homemade. First of all, they were homemade. Secondly, they didn't eat the whole bag of sweets every single time. They only ate one sweet probably.
And moderation.
If
Yeah.
you could come to a life saving course and you're given all this
Yeah.
delicious sweets and things like that.
The Smith salt and shake, you have to add the salt
good
to
catch.
it.
So these things are
Yeah.
important to recognise, okay? We spoke about having fractures and broken skulls and things. So the fracture itself might directly injure the brain, or it might not directly injure the brain, but it takes away the normal protection of the brain. So they might have all the brain injuries, and then added onto that, they have a sharp bit of skull poking into the brain as well. So you do need to think about that, okay? And be really careful with people, especially if they have a lower level of consciousness to what they normally have, and they've had a head injury. Be really careful. They might have a skull fracture. That's difficult to determine. I remember seeing a patient who fell over and had a basal skull fracture, and it wasn't picked up because they picked themselves up. I was in medical school at the time, and this was in hospital. There was a hospital patient, went outside, had a smoke, fell over, came back, and 2 days later had bleeding around the eyes and stuff leaking out of the ears. And someone said, "Look, what happened?" And they said, "Oh, I fell over." And then they had a scan, and then they fractured the skull. So it does happen, and you need and it's being aware of the things that you need to be looking for to pick up.
And you don't have to show signs of a serious head injury to have a fractured skull.
Yeah.
The last one I dealt with was last week. Yeah, 15-year-old girl. She had been hit by a lorry, to be fair.
Yeah.
But fully alert, fully awake, conscious. Problematic to deal with, but she probably, according to her mum, had undiagnosed or yet to be diagnosed autism. So the behaviour that she was doing on scene was put down to being normal. We weren't happy with that, so she wasn't cleared by us, and in fact she was taken in as a priority because we wanted her scanned. She was scanned, had a small bleed on the brain, basal skull fracture, quite a few others. Completely undetectable externally, and nothing showed us that, except the fact that we'd seen these patients before, and we weren't happy that she didn't say.
And just remember, it's not your problem to sort out the patient. It's your problem to get the patient to somewhere where someone else can sort out the patient. Yeah? So if they've had an injury that is suspicious, treat it with the due suspicion, rather than say, "Oh, you're behaving normally for you now. Goodbye. Don't worry about
It's
it."
also probably highly unlikely that when you've been hit by a lorry that there aren't going to be any injuries, isn't it?
It's very
It's going to
unlikely.
be something.
The bigger the vehicle,
Yes.
the more
Yeah.
likely, yeah.
Yeah. But the flip side is that you can get people with underlying health conditions that even a smaller or relatively smaller insult will give them just as big an injury. And you don't know what that person does beforehand. So young girls, be suspicious, especially if they're thin, because they might be anorexic, or young boys as well. When I say young, we talk about teenagers or young 20s. That's usually when they'll start presenting with anorexia. And because of their mental health, that affects their physical health, and their bodies behave like a much older body and a much frailer body, so they get these massive injuries. And someone who's been given a diagnosis of learning difficulties or neurodivergence, autism or Asperger's or ADHD, there's a quite a big crossover with mental health, so they might have these things. So the idea isn't to scare you, but it's to make you think, actually, it's quite easy to miss these quite significant injuries because they're quite difficult to pick up. And they're difficult to pick up for anybody outside of hospital. So when you had a FREC 3 course or a FREC 4 course, and that's all your knowledge, don't be tempted to say, "You look normal," because there's so much more that can be going on behind it.
Any head injury, don't take a chance.
Yeah.
Take
Well, yeah. If they've had a clear head injury, why take the risk with it? I mean, the hospitals won't take a risk with it. Yes, at the very least, if they look completely fine, they'll still put them onto 15-minute neurological observations. So every 15 minutes, that person will have a nurse come and look at them and do a full scoring system on them. And if they happen to have that at night, they will not sleep that night, because every time they fall asleep, someone will come and wake them up.
I mean, but how many times did I bang my head as a kid at school? Like, you know.
I'm not talking about when you banged your head and you haven't called an ambulance. I'm talking you hit your head and you called an ambulance.
It means you bang your head harder.
You banged your head hard enough for someone to worry about it.
Right.
Yeah. So
Head injuries, when you're going to move into advanced practice and you work in walking centres and you're trying to deliberately take the load off of A&E, they're really awkward.
Yeah.
Because you just don't know. And there is some then risk balance that you have, but there is quite a lot of risk in managing these patients away from acute settings. So
It's
don't.
like how do you triage?
Yeah, so
a
don't.
head
Just take
injury?
The answer is
Yeah,
don't
don't.
triage because it's so difficult that
Just
don't.
if they've called an ambulance, they go to hospital. If
Yeah.
they never call you, you're never there to make the decision.
Yeah.
Okay. And even in hospital, there will be consultants usually who make the decision. Even if they're seen by a senior registrar, they will have a chat with the consultant. They have to be quite senior to be allowed to make this decision on their own. Yeah. So don't be there to reassure the person who's called you because they're worried. Okay. Again, they might have signs of concussion with this injury. So don't forget, just because we can see an injury doesn't mean there isn't another injury underneath it. Okay. It might be obviously might have some bruising or some swelling or bleeding from where they had the injury. But again, it might be quite difficult to tell, especially if it's night time, or if they have a large head of hair, or if they're Afro-Caribbean and they have an afro. Yes, so the hair might cover a lot, but hair isn't a helmet, and it doesn't give you protection. Okay, so just remember that. You might feel a soft, boggy area on the skull when you're examining it, and that's usually to do with the bruising. But you might not. You might feel that the skull is out of shape. You might get bruising around the eyes or behind the ears. So in Europe it's called panda eyes. In the United States it's called raccoon eyes. It means exactly the same thing. It's just where you get a black eye. Yeah. So that and that what's happening there is you're getting blood trickling under the skin, and the eyes and the ears are the lowest point in relation to the skull in that aspect. So that's where the blood collects, and you see the bruising over there. Okay. So if it's around the eyes, it's called panda eyes, unless you decide to go to the United States, in which case it's called raccoon eyes, just because pandas are known everywhere, and in the United States they also have raccoons. If you get the bruising or swelling behind the ears, it's called battle sign, and that's not because it's something that happened particularly to soldiers in battle. Although they did get a lot of head injuries in the days of hand-to-hand fighting, it's because of an anatomist called Mr. Battle. You might get some bleeding from the nose or from the ears because that's again it's where it's going to drain to, and it can sometimes be quite difficult to tell, is this just normal blood from a nosebleed because they've been crushed on the nose, or is this blood coming from the skull and it has in it a liquid called cerebral spinal fluid mixed in with it, which is more of a straw-coloured liquid, and it can sometimes be quite difficult to say. So if they've had a head injury and they're bleeding from the nose, don't say to them, oh, it's fine, it's a nosebleed, because you don't know that. Okay. And then you might look at them and you might notice that they've got an asymmetrical looking head, and you might see some bleeding in the eyeballs and things like that. Again, all these are things to give you signs that they have a serious head injury, but they might not always be there. So you need to be careful with them, but don't falsely reassure yourself when nothing's there. Okay?
Bleeding from the ears, particularly from inside the ear, that's almost always come from somewhere with skull fracture, because it can't come from anywhere else.
Okay.
Is it usually something else coming, like the grey?
So it might be a straw-coloured greyish liquid, which is cerebrospinal fluid.
That can come from the ear as well?
It can come from there as well. But remember, they've had to have an injury that's broken through their skull to allow that fluid to escape. So it's very likely to be mixed in to have blood mixed into it. So you might not see that. So it might look like it's just blood, but actually it's not just blood. Okay. And I don't know, were you taught when to check bleeding from ears and nose by putting it into gauze to see if it gets a halo effect?
Yeah, although we never actually did it, but yeah.
Yeah. So there's a theory that if you take this blood and you put it on a piece of gauze, the blood will concentrate in the middle, and the cerebrospinal fluid will spread out around, so it looks a bit like a sun in a cloud egg. But it doesn't actually work because it's usually so mixed in and so difficult to tell. So if they're bleeding from the nose or the ears after having had a head injury, they've got a basal skull fracture until they've had the CT scan that says they haven't. and sometimes the CT scan might still miss it. So I know of one person where the CT scan has missed their base of skull fracture. The problem, it was fine because it was a very stable fracture, which is why it was missed on the CT scan, but
Yeah.
the point is, don't be falsely reassured without the CT scan, which you don't have in the back of the ambulance anyway. Okay? They'll say, ah yes, you've got a nosebleed, we see loads of those, pinch your nose off, you go, see you in 20 minutes.
You guys happy with what the base of skull is?
Oh, sorry.
Base of skull. So, because when I was first taught this, I assumed it was this bit. It isn't. It's
So,
this
so your skull is a closed
I was
box.
thinking as well,
Yeah.
So your skull is a closed box, okay? You've got the hard bit that you can feel, which your bicycle helmet sits over, and then you've got the bottom of it, which is basically a straight line just underneath your eye, just underneath the eyes, going all the way straight through your ears into the back of the head, and you can feel the base of the skull when you press on the back of your neck. When you press just that hard bit there, as you bring your fingers up your neck,
The little bumpy bit there.
that little bumpy bit there,
Where the knot goes.
where the knot goes, yeah, of your filling, that's the base of the skull. Okay? So underneath it is spine, from there above is brain. Okay?
So there's two separate parts, this and this.
It's not separate, it's a box, but it's the base is the flat bit at the bottom, which is basically a line going this way, and that's why you get bleeding from the nose when it breaks, because it's just above the nose.
Oh, I see, it's here to here.
Yes. Okay.
So this is jaw.
So your jaw attaches onto the base of the
Yeah.
skull.
So the roof of the mouth effectively is part.
No, the roof of
bottom
the roof of the mouth is the next layer down. It's the roof
one
of the
there
nose.
already.
The roof of the nose is the
Oh, of
base of
course,
the
yeah,
skull.
yeah, yeah.
Okay. And you need a lot of force to break that because it's quite a protected part of the brain, of the body. Yeah, but it does break. So yes, so if you notice any bleeding from the ears or the nose, especially the ears, the only place it can come from is from the base of the skull, really. So treat it really, so treat it seriously. Okay. Now, sometimes what these injuries can do is it can shake the brain stem, which is the bit of the brain that comes out through the base of the skull, through the foramen magnum, into the spinal cord, and that's the bit of the brain that controls all our automatic functions. So it controls breathing, it controls blood pressure, it controls heart rate. If this bit gets knocked, and remember it's sitting there in a column of stone or of bone, and it can get knocked against that, and it will get pulled with the brain and knocked as well. So it's more at risk of getting these type of injuries. And if it gets knocked hard enough, it just might make the patient stop breathing. Now it will recover, but it will take it a few minutes to recover. And the problem is, while it's recovering, the person isn't breathing. Okay, so what will happen is the patient will immediately stop breathing, and if you don't recognise it, the patient will continue not breathing. And while they're not breathing, the brain itself is getting an injury from not having oxygen, and then the brainstem will eventually recover and they'll start breathing again, but they'll die because the brain has died. Okay? So again, it's important to think about that and think about recognising these things might have happened. So if you get to someone and they've had this sort of injury and they're not breathing, think, is it, and they've got a pulse, it might be that they've had this type of injury.
What would
Okay?
you do?
You open the airway and you get a bag valve mask and you ventilate them, and then they recover. And
So
these
despite that concuss the
Yes,
stem, it's
because
not,
despite the
it's not
fact that
compressing the airway,
yes.
it will still allow. It's just not
Yes.
doing it itself.
Yes, exactly. And these are the patients who on the 10-second triage might be not breathing. If you put them in the recovery position, then start breathing again.
Yeah, but not with the jaw.
But the jaw thrust, you can't do a jaw thrust in major trauma.
Yeah.
So the least risky thing for them is to be in the recovery position, because if they've got a serious injury that's severed their spine at the brainstem, it doesn't matter that you put them in the recovery position. It's not going to cut it any further. But if it's not severed and they've got this apnea from concussion of the brainstem, and you let them lie there and they block their airway and they can't, and then they try to breathe and they can't, they'll die. Whereas if you put them into the recovery position and then they start breathing again, so they'll recover. Okay, but you can't. But if they haven't breathed for long enough for the brain to die, then again you haven't made it any worse.
There's a theory with this from the Isle of Man TT, isn't it? Which, what's his name? He died, didn't he? John Hines?
What I don't know. There were a couple of brothers who were
Yeah, so there was
racers.
a doctor, a medic that used to travel behind the Isle of Man TT on a bike, and they would come up to patients that were dead, and they couldn't find any injuries. There was nothing on them at all. When they did post-mortems, there was no injuries either. And they were, like, obviously were really high-level riders, so they were wearing really good kit, and they couldn't figure it out. And then they started to look at this, where they've got an impact, the helmet's keeping the brain intact, everything's fine, they are going unconscious, their airway is obstructed, they're not breathing, and there's no one close enough to open that airway, and they never restart. So he started following them close behind on his bike, so he would race the pack, was there quicker, and they started to see survivors because someone was opening the airway.
Okay. So and that's the truth of the matter, that you might get these things might happen. Okay. So the way to recognise it is the story is that the patient had an impact and immediately stopped breathing effectively. And it depends on how hard the impact was as to how long it takes the brain to reset. So the harder the impact, the longer it takes. So if it's a mildish impact and they stop breathing straight away, opening their airway might be enough. Whereas if it's a much harder impact and it's going to take them a couple of minutes, they might need ventilating as well during that time to allow the brain to recover. Okay. Yeah, and that's what we've said. If they're not ventilated, then the patient will die. And we went to a cardiac arrest here in Edgware a couple of months ago, where the patient had a brainstem bleed, and they presented with stroke symptoms, but they collapsed because of the bleed. And there were members there who treated the cardiac arrest immediately, and after 2 or 3 cycles they had return of circulation. And probably what happened is the brain stopped breathing, collapsed because of the stroke, then weren't breathing because of the brainstem injury, and then the members started resuscitating them, but as part of that ventilated them, so therefore their circulation picked up again. Unfortunately, the patient had an unsurvivable brainstem bleed, so they still died, but the pathology was that they died because they couldn't breathe, not because of anything else going wrong with it. Okay? So it's important to recognise this, okay? So then thinking about the spine, so we spoke about this, there's the 4 main bits of the spine. So there's the cervical spine, so that's the neck bit, okay? And the higher up you break the spine, the more problematic it will be. So for those of you who were learning Dafyomi at the end of last week, it was talking about if you paralyse an animal, at which point can it no longer survive? So it's exactly this. The higher up it is, the more nerves you take out, the less likely the body is to be able to continue functioning. So if someone takes out the cervical spine, it's obviously going to take out a lot more than if it's lower down. Okay. So you've got the cervical spine, which is in the neck. You've then got the thoracic spine, which is the bit where the chest is, and the ribs attach onto that. You've then got the lumbar spine, which is basically the abdomen, and that's from above your hips to just below your ribs, and that has no muscles attached. That has no bones attached to it, so it's all muscle around it. And then you've got the sacrum, which as babies is 5 separate bones, but then fuse as you grow up, and then it creates a ring with the pelvis. And then you've got the coccyx at the end, which again is bones that fuse but have no real function because they're just there supposedly an evolutionary remnant of having a tail, basically. And it's just there to give you lots of pain when you're having a baby, or if you fall on it. Have I got that right?
Yeah, pretty much.
Yeah. Yeah. So it's really painful when women are having babies because it points in the wrong direction, basically. And if you fall on it, it can break, and then it's really painful. And then you have to sit on a donut for ages and ages and ages to take the pressure off.
On the tire.
What?
On the tire.
On a tire, yeah. Okay. So things that would tell us that someone might have a spinal injury is pain or tenderness on the neck or the back. But remember, if they've got other injuries, then they might not notice those. Now, I didn't find any more bottles or cans of Coke. There's cold water in the fridge. So they might have pain or tenderness in the back. If it's impacted on the sensory nerves, which are much smaller nerves, so therefore the ones that are more likely to be injured earlier, they might have a tingling or pain sensation, or they might have no sensation, so numbness if that happens. And if it affects the larger nerves, the motor nerves, then they'll also have a loss of movement with it. And the thing that commonly will happen if they do have these injuries is they'll have loss of bowel and bladder control. So either they won't be able to go to the toilet, or they become incontinent. And they become numb around the pelvis area, around the groin area because of that. So what we call saddle anesthesia. So imagine you're sitting on the saddle, the bit that you're sitting on loses all sensation. If it's really high up, because of the way the circulation works, in men they'll get an erection. Yeah. But it's not that they're around. It's just to do with how the circulation works. Okay? So people who are hung, men who are hung, invariably had an erection at the end of it, to do with blood pressure. But you might see that on a patient who's had a high spinal injury, where it's severed through the nerves, and they might have an erection because of the effect that's had on their nerves.
Every cloud.
Well, not really, because they don't know, because they can't feel it.
Alan.
Yeah. Okay. So what are we going to do if we suspect someone has a head or spinal injury?
Well, if you have to move it, you can make the neck brace at one.
Yeah, so we need to think about that. So we're going to first of all make sure that it's safe that we don't get injured by whatever's caused the injury. And we're going to have a look, as Richard was saying, is it a motorcyclist where the motorcycle is at one end of the A41 and they're at another end of the A41, and there's no physical connection between the two other than a large skid mark a while before you get to them. And you think, well, actually the head is a large weight attached to something quite flexible, and it probably shouldn't have been moving around the way it did. And they're lying there like this. So look at what might have happened. Have they jumped from somewhere? And so classically jumping into a shallow pool of water, landing head first, so their head gets knocked, and they might have an injury from that. Get someone to help you if you're not there as they help, because you'll need more help because it takes more than one person to look after a person who has this type of injury. And then after that, we'll assess and provide emergency care to the patient. Okay?
What is considered mechanism?
Think about how the injury happened. So my example of the motorcyclist with a large skid mark, a gap, motorcycle on one side of the road, motorcyclist somewhere else. Mm-hmm.
So I just took two at once.
Yeah. So that, or a couple of years ago, there was a motorcyclist on a Harley Davidson who decided to park the Harley Davidson right in the back of a brand new Audi A8. The motorcycle was sitting very nicely wedged into the boot of the Audi A8 with the front wheel in between in the 50-50 split of the back seat. And the motorcyclist was lying flat on his back on the roof of said Audi with a broken window as the front. So basically, he went in, flipped over the car. So think about all those mechanics and energy that's gone into this motorcyclist. As he flipped over, he's done a 270 flip, and his head was the pivot point, and he was quite a large chap as well, so think about all the energy that could go and the injuries that could happen. He didn't manage to break very much apart from his dignity, but never mind. Oh, and the brand new Audi A8. Okay, so think about these things. Okay, does that all make sense?
No, but I don't know what is the access mechanism.
So think about what sort of injuries might have happened to that person. So my example of the motorcyclist who flipped over an Audi, where his head is the pivot point. Yes. If I grab your head
This picture.
like this,
Yeah.
and I'm going to now flip. Come on, keep going. You need to do a flip. Can you flip?
Me, no.
Okay. So think about how much energy is going into that neck,
Spinal.
because it's the spine and the rest of the body going all the way around. Yeah. And think about all those forces and what sort of injuries that we might predict that they can do.
With blunt force trauma particularly,
Yeah.
it's about transfer of energy. So you drive a car into a tree, that energy is transferred rapidly from what the car was doing into the people in the car when it stops really quickly. If you rear end someone, you both come to a stop, that energy is transferred slowly, less of a problem. So in that instance, the transfer of energy is rapid because the bike has stopped, sorry, the car has stopped, the bike has kept going, and it's a rapid stop. Same as if something falls from height onto heads, there's a transfer of energy. Transfer of energy breaks bones, your spinal column is the vertebrae of bones, the same as anything else. So if you've transferred enough energy, if you're hit to break an arm, if that is transferred to your spine,
It will break
that
the
can
spine.
break the spine.
And it doesn't need to be a huge amount of energy. I've got a number of patients who were cleaning fridges and freezers, toppled over backwards, and said fridge and freezer fell on top of them and managed to break their spine. And the only thing that they presented with was pain. And I remember that I've got one memorable patient who's still alive very happily and is very thankful to me. But she came to see me 3 days running, saying that her back is hurting and it doesn't matter what painkillers I've given her, and I rapidly increased the painkillers. So we started off with codeine. By day 3 we were on quite significant amounts of morphine, and she said it just wasn't touching the pain. And the reason it wasn't touching the pain was because I told her, you've sprained your back, keep active, and here's painkillers. And every time she was keeping active, it was moving that broken vertebrae, and it was absolute agony. And on day 3 I had had enough. I had run out of ideas and I'd run out of bravery in increasing the morphine. So I sent off to A&E, and they did an X-ray and discovered that she had broken a vertebrae in the spine. And guess what they did? They gave her more morphine and sent her home.
There's nothing else they can do, isn't there?
Told them not to move.
No, they told us to keep active, but gave her more morphine. So I was doing all the right stuff, but I just didn't have that knowledge. So at day 3 I chickened out, but that's the point. Think about the the mechanism of the injury. What sort of things might have been injured in as part of that.
So if for a motorcyclist injury, if their helmet is still in place, is that a sign that their head is less risk of a major injury? Or?
So, yes and no. Because it might be that all the energy has been transferred into their neck and the helmet is intact. It might be that there's a lot of, or there might be a lot of damage to the helmet, and it's done what it should do, which is protect the person. Or it might be that there's a lot of damage to the helmet and the helmet has failed structurally and transferred all that energy to the patient, to the person. Okay, so that brings us rapidly to the question. So what would we do to someone who's wearing a helmet?
If you suspect the neck injury, don't remove it, do you?
Yeah.
Unless they're not breathing, whatever. If they were breathing and they're
Okay.
stable, I wouldn't remove
Yeah,
it.
you do remove that.
So how will you know?
How do you know what?
You remove it.
How would you know? You've got the person lying on the floor with their helmet on. What are you going to do?
You wouldn't know, you would suspect the spine spinal injury either way.
Yeah, so you have to suspect a spinal injury, absolutely, because the mechanism is there. So what are you going to do?
You have to take it off.
Put the collar, obviously.
So the problem with the helmet is that it's quite thick. It's got about 5 centimeters of thickness to it. So it's lifting your head off the floor 5 centimeters. If they're wearing one of the modern helmets that actually has the face visor and it all comes down, where are you going to put your collar? Yeah, because it comes down to the neck, so it fills in the space that you're, in theory, going to put your neck brace into.
It's also closing up your airway as well, isn't it?
Yeah. So again, remember, it's pushing your head forwards.
Yeah, in that case, I'm assuming it's just a two-man job. One of them holding slowly, gradually, holding the head.
Yeah. So what I would say is the
Check
first.
the response. Check the
The,
response.
the first thing, yes.
If it was from
So before you remove it, what I would suggest, the first thing to do, and correct me if I'm wrong, Richard, first thing I would do is I would open the visor and say to the person, "Hello, I am," and
That's the best way you'd be able to do your Dr. ABC, isn't it?
yeah. So if the visor's closed, that person can't see you, can't hear you, can't breathe possibly. Whereas you open the visor, you've now got a human-to-human connection.
Or human to mincemeat.
Yeah, but
then you can see that once you open the visor.
But then you can see that once you open the visor, absolutely. So the first thing I would say is open the visor. Now if it's one of those fancy helmets where the chin bit comes up as well,
Flip up.
the flip-up helmets, yeah, then get that open as well, because that will hugely help you get the helmet off the person, because it won't get stuck in their nose as you pull it off. Okay?
But this one automatic, when you get impact, usually like, I'm not getting a lot of impact, but usually when even if you stop hard with the motorbike,
Yeah, but I'm saying once it's clicked closed, and the person is lying on the floor there, and it's closed, and it's blocking their nose and their mouth, and pushing their head forwards, so it's pushing their tongue back into their neck, and they're lying there, you want it open so you can talk to them, and if you can open the flip up bit as well, that will help you get the helmet off. Because the helmet is designed to be quite a snug fit, and part of the problem with it being a snug fit is that it's hard to take off. And it's hard to take off because it's designed to protect the head like that. Okay. So open it. Look, listen, and feel for signs of life. So are they looking at you? Can you see them breathing? And it's going to be a balance when you take the helmet off. You might take it off immediately because you need to do an airway intervention. You might do it in a little bit of a more controlled way, when you're immobilizing the patient. If you're doing whatever you're doing, just remember the helmet is a snug fit, so you can hold the helmet to keep the spines immobile. So it won't move because the person won't move while they're in the helmet.
I'm assuming there's no rush to take the helmet off if they're talking to you and they're calm.
Yeah.
Is there a rush to take it off there and then, or can you pick
No,
up how you're going to do it?
you can think about how you do it. Whereas if they're not talking to you, and you're not sure if they're breathing or not,
Okay.
you'll be in a bit more of a rush to take the helmet off. But you still need to remember that they might have a spinal injury, and you have to be careful with how you
Be
do it.
careful, if they're not breathing, it's not going to make a difference either way.
Yes, but if you break their spine
Well, I'm saying
while
they're not-
taking it off, and then they can't breathe, as opposed to they're not breathing right now because they've got brainstem apnea. Yes, so part of it is about not making things worse.
Yeah.
Okay. So there are ways to take off the helmet, which involves unclipping it, number one, because most motorcyclists that I see don't clip their helmet on properly, but invariably the one who needs it clipped somehow do get it clipped. And if you try removing it while the chin strap is on, it's not going anywhere because it's designed not to go anywhere. Okay, and then you need to slowly rock the helmet off, so you're not taking the person's nose with it. And while you're doing that, you need someone else to be supporting the head and following the helmet upwards to hold their neck, so that they don't. So you don't take the helmet off and then they drop the head backwards and get another head injury on top of the injury that they've had already. Okay.
In case your was fine, we could cost it. Sorry.
So
Yeah.
Do I need to put like a support behind the head, or you just let it slowly?
So when you as you go up as you take the helmet off, yes, someone else is following with their hands up like that and holding the head in the place where it is, and then you gradually bring it back into a straight position. So you're not really moving it. You're not really moving the head that much.
So they're not too sharp movement. Basically, not to do sharp moves.
Yeah.
So what we tend to do, and what PH Tillis and stuff teaches is that 2 people need to take the helmet off safely. If they have no air when you've got to do the airway, that's the risk balance, and then you may do it with 1 person. I've done it on my own for someone that's unconscious. I have to get into the airway. But if you've got time and there's 2 people, one of you stands at the front or
In front of the person.
in front of the patient, yeah. One hand goes up the front of the helmet as high as you can, and you try and get a bit of purchase to support on the cheekbones. The reason you use the cheekbones is that's the solid bit. If you try and use a mandible when it's broken, it's going to move. So cheekbone, and then the other hand comes as high as it can at the neck. And then the other person who's behind has the hands in the helmet. You pull, so this part of the helmet, pull it apart as much as you can, and you do that rocking motion, one to get it past the nose and the other to get it past that bit, the back of the head. You move it slowly as the helmet's moving away from the head. Your hands can stay there at the front, but this hand comes up to find as much of the head as it can until about there. Because once the helmet clears that bit, if you look at the picture, the helmet's keeping me off the floor. As soon as you remove the helmet, I've got that gap, and the head will go like that, so your hand is there to support it. After that, then if you need to, you can put stuff under it to pad it into a what you call neutral position, so the normal place, but it's to stop that drop initially, particularly if they aren't conscious, they're not going to hold, or they've got a neck injury, they're not going to be able to hold it in place. So it's to support that and stop it dropping.
Will you help me when it's at the back, like to get clear airway, like instead of do a jaw thrust, what do you think?
No, so the problem is you don't want to do a head tilt chin lift in these people because that's going to make any neck injury worse. So they have to have a jaw thrust. Okay? So as you take the helmet off, you're going to support it so the head doesn't fall, doesn't drop backwards, but then your airway manoeuvre is going to have to be a jaw thrust after that. Okay? Okay? Any questions about head injuries and spinal injuries? Okay.